Just admitting everybody now. Hi, everybody. Thanks so much for joining us. I'll pass over to Bea from the LHD to get us started. Thanks, Bea.
Thank you, Katie. Hi, everyone. We are very thankful for everyone to come to our evening sessions this evening. We are from the TRIX eCare team, which is a transnational research grant scheme that will be implemented in Western New South Wales. Before I formally open this meeting as well, introduce our team, I would like to give the acknowledgement. And I think, Katie, if you would like to acknowledge just so we can formally open today's evening session.
Yeah, really happy to, Bea. So to begin our meeting tonight, I would like to respectfully acknowledge the Aboriginal and Torres Strait Islander people as the traditional custodians of the nations and countries on which we work and that we're meeting on today. I'm sitting in Bathurst and I'm on Wiradjuri country. I pay respect to elders past, present, and I extend that recognition to all Aboriginal people in this meeting today. I acknowledge that many Aboriginal language groups across Western and Far Western New South Wales, which reflects the rich cultural diversity of First Nations people. I honour elders as knowledge holders, teachers and pioneers, the youth as the future leaders and hope for a brighter future, and remember those who have gone before us and all their contributions to the community. Thanks, Bea.
Thank you, Katie. Again, thank you so much for everyone that come this evening. I'm actually the co-chief investigator in this research project with Professor Glenn Maberly that actually also come this evening from Western Sydney Diabetes. I'm a senior health economist with Western New South Wales Local Health District. We actually have also a lot of our internal team members here. There are Professor Jensia Wong also coming as a part of the Meta Diab. There are Anna Blakey from our Western Diabetes Hub, Associate Professor Carissa Bona from University of Sydney also coming, and also Dr. Gideon Merritt-Katz also attending today that will go through our clinical trial in more details. Just a little bit of note keeping before we hitting the first agenda of today is actually this meeting we put a recording for this meeting. For anyone who have concern, please let us know. Maybe for the first event of this evening, Professor Glenn Maberly, do you want to do some introduction to the Western Sydney Diabetes?
Hello, everyone. Let me see if I can share some slides with you. Please tell me if you can see them okay.
Yes, we can see them.
Okay. So for those that came to Dubbo, some of this material is a bit similar, but what I want to do today is tell you a little bit about why we're here and what we're trying to do with you. And what I want to say is, of course, acknowledgement of country, and of course we recognise the Aboriginal land and respect Aboriginal people and their elders. But I want to take another acknowledgement of country approach, and as a city-based clinician, I also want to acknowledge the vast rural communities, and this allows us to join in your good work and enrich your experience. So the Western Diabetes team are really excited to be able to be with you on this journey, and we hope that we together with all of our partners here can really make a eCare program pretty effective. Essentially, Western Sydney Diabetes has been active for about 12 years, and we have about 1 million people in our patch that we look after here, and we have about 140 partner organisations that are sharing the goal of beating diabetes together. And you can see this sort of strong alliance that has kind of brought us together. Why have we had to do things and think about things a little bit differently? Because we know that the burden of diabetes in our patch, and I think in your patch, is everywhere. So 20% of adults who've seen an ED and who are seen also in GP practices have diabetes, and 30% have pre-diabetes. So half our population are affected, and it is really expensive. So we work on a couple of priorities. One is early detection, and we have a program that every adult who comes into GP practice has a hemoglobin A1C test every year and are connected up to a lose 2 kilogram challenge program. And the second one is the integrated care package, which we are hoping to share with you and work with you through this eCare grant. Essentially, the package goes from a referral from is our model of care in Western Sydney at the moment. Referral from a GP. They see an educator who explains the program, who puts on a CGM. You come together in a case conference. We come up with an agreed management plan, and we follow through on 1 or 2 or 3 follow-up consultations. So it all begins too with the patient getting a survey about what their needs are. And obviously these are some of the things that you would want to be putting in your referral, as I'm sure you always do. And we hope that you can also prepare your patient to know that the experience is going to be a little bit different to a normal specialist consultation. And then when you come, we need to all be there on time to see the patients together, and that works really well where we are. And we spend a little bit of time going through the CGM and coming up with the agreed plan. Now, we have in this eCare some funding for the practice, and we have some funding for the GP, and there's some patient support as well. But you're able also to claim the MBS items, and we would be thinking about those 2 items. There's a short case conference and there's a longer case conferences. We tend in Western Sydney to do the standard one, and this is what the GP can also claim on MBS funding. So we welcome you to join us, and we hope you can and become a partner in this process. This is a little bit about the educator session and also the sort of case conferencing. Our model of care is very similar to what you would expect. We focus on these 3 pillars: glucose level management, weight management, and organ protection. And we take the patients through the journey of the 5 M's, all the measurements, the medicines, the meals, the movement, and the mindfulness. And then we have that agreed plan of action, and we have follow-up. This is a little bit of the priority setting tool for patients, and we find out what they want out of the process as well. I think the big game changer that we have been using for 10 years is the use of a CGM. It's a small sensor that you wear. It's put on for all the patients, and it can really help them see what's going on, and also for us to see what's going on. So there's something there for the specialist, there's something for the GP, the diabetes educator, and the patient. And we also have available an app called Diabetes Together, which can capture all this material. You can take photos of your food, and it can do friendly coaching about what to do with diabetes. Patients really like it and call and say it's a real game changer. So in eCare, we're bringing the specialist diabetes support to the general practice. We're doing the virtual case conferencing, the CGM and Health to Sync. We're doing some upskilling of the GP with support. It's very flexible, it's easy, and it's amazing. When it works really well, it really does work well. And we've had about 800 GPs join us in this model of care, and we're wanting to give you the opportunity to work with all of our teams to bring it together. We have all of these organisations, as we mentioned up front, have come together as our partners in Western New South Wales, as well as we have some support from our pharma companies that allows us to do some of the, particularly the educational material, including they supported the masterclass that happened in Dubbo recently. So I hope that wasn't too bad, a gallop, but it kind of sets the scene for you, if you like, of what you might be anticipating and we might be working on together.
Thank you, Glenn. I'll be moving now to the second event of this evening. Jensia, are you presenting for the So we will now actually talk about the MetaDiab and virtual case conferencing clinicians. If you have something to presentation, you can share screen. Or
I've just, you've got me, Bea, if that's all right. So
no, that's okay. Yeah.
Thanks so much. And hello everyone. It's such a pleasure to be here and to discuss this exciting innovative project. I'm here, I wear many hats. I'm an endocrinologist in Sydney, staff specialist, a clinical professor at the University of Sydney, a VMO at Dubbo Base Hospital, and together with Dr. Ted Wu, who sends us apologies, we have set up a service known as MetaDiab. And this was set up particularly because we've both been working in Western New South Wales, I think cumulatively for about 25 years. So we've been, really committed to the region, and we've seen this need for virtual diabetes care. And so MetaDiab was really established to provide a number of virtual diabetes care programs, which are delivered by specialists to provide not sort of management, but actually consultative support to primary care to Western New South Wales. So it's a real pleasure for us to be invited to partner with the eCare Triggs project, because we're extremely aligned in terms of the philosophy of supporting Western New South Wales, but also delivering case conferencing with the benefits of attendant technology, and Glenn's already established, well-established leader in that field, and the definite benefits that we can see. So MetaDiab will be part of the Triggs eCare, and we'll be providing some of the specialist services to support the case conferencing. And with the vision going forward would be that we would hope that post-trial that MetaDiab may be able to continue in providing the sort of services that have been modelled here, and I'm assuming a very positive outcome. So that's all I was going to say from me.
Thank you so much, Jensia. I just want to let everyone know, while we will have a Q&A at the end of the session, if anyone have any burning questions, happy for you to just put it in the chat. If there's questions that are quite easy, we can definitely respond directly in the chat. The next one is a presentation from our Western New South Wales Diabetes Hub. Anna, yours, please. Thanks.
Thanks, Bea, and thanks, everyone. It's lovely to be here. Can you see my slides there?
Yes, we can see that.
Beautiful, thank you. Look, hopefully, so my name is Anna, I'm from the Western Diabetes Hub, and I just wanted to provide hopefully a quick overview of our service and I guess how it operates at the moment and how we'll be fitting into the to this eCare trial as well. So hopefully lots of you are aware, but the Western Diabetes Hub is a service, a virtual service that's available across the Western and New South Wales district for people with pre-diabetes and type 2 diabetes. We largely do all of our consultations via video or telephone, but we do in person where we can, and we link in really closely with staff that are available in local communities. And we're here not to duplicate not to duplicate, but we're here to really fill gaps that exist across our region. So where perhaps there's a lack of local services, or sometimes we work with other services where there might be waiting periods, we might help in that transition between a hospital admission back to community. Or sometimes people with busy lives just might prefer a bit of a telehealth, especially where we can do joint consultations with our allied health team. So we do have allied health, and we also support access to endocrinology services like Jensia was just mentioning. So this is our team. You can see a map here of our very large district, and in red, in the red stars is where our team are located. So you can see that they are located across the district. So we do have not just clinical experience, but lots of knowledge of the region and of service providers that are available. And also within our team, whilst we're based at the local health district, we do have a number of team members with a lot of experience across the health sector, including primary care. So you can see the allied health here that we have available. We have Aboriginal health practitioners, diabetes educators, a dietitian, and an exercise physiologist. And really importantly, we are very lucky to have administrative support as well. So we currently receive referrals from many different sources, including self-referrals, community screening, but also from primary care, general practice, and other LHD sort of services. The way our model works at the moment is it's very goal-directed care. So based on the goals of our patients and our clients, we work with them. And we also do a lot of care navigation. So like I mentioned, we're not here to duplicate. We do a lot of linking with other local services that are available. That's a huge part of what we do. So in terms of the services, they're things that you might expect from a multidisciplinary diabetes service in terms of self-management, sick day management plans, support with insulin, for example, or glucose monitoring, CGM, lots of care navigation. And we also, our team is able to be involved in case conferencing. We do provide support for case conferencing, metadiab, and also we do lots of community events, community screening, and education for whether it's LHD staff or also for primary care clinicians as well. In terms of the eCare, we will be having a research nurse based in our team. So that will provide a really strong link with the hub team supporting the practices that are involved in this particular project. We'll also be providing that administrative support for, organising the case conferences with our team, and also the allied team, our allied health team can be involved where needed. So whether that's during the intervention and the case conferences, or a referral pathway, after the study to our service, or we can be providing that care navigation as well to make sure people are linked in with the most appropriate local service on an ongoing basis. So just up on the screen there, that's our email address there, which is a really great way to contact us.
Thank you so much, Anna. And the next presentations will be from our University of Sydney team, which actually will be responsible for qualitative component of this project. Carissa, are you there? Yeah, I think.
I am here. Hello everyone. And I've also got Hazel here, who is on my team. So we're representing a bigger University of Sydney team today. So I'll just share some slides. It shouldn't be a long presentation, but also happy to pause and answer any questions. Can you see the slides?
Yes.
Great. So I'm just speaking today on behalf of the Sydney Health Literacy Lab. We have a very long-standing collaboration with Western Sydney Diabetes team through supervising several PhDs and a few different projects, including this one, all relating to virtual care models for diabetes management. So as the name suggests, we specialise in health literacy, but I am also an implementation science fellow. So for the purpose of this project, I'm going to be leading an implementation science component of the evaluation. So I'll just quickly introduce our team. Kirsten McCaffrey is the director of the lab. I'm the deputy director. Julie Eyre is a research fellow and an expert in co-design and digital health. Samarthi, you may know, who is a program manager at Western Sydney Diabetes, and she's also doing a PhD with us, which is just about to finish. And Hazel, I'll just get you to quickly introduce yourself as well.
Hi everyone, I'm Hazel and I'll be assisting Carissa with the implementation side of the project. So yeah, you might hear from me in the future when we start running our focus group. So yeah, lovely to meet everyone.
Thanks, Hazel. So I'm just going to give you a very quick overview of how we plan to do the qualitative side of the evaluation for this program, which will be after the trial has finished, but there have been a few steps to do before that as well. Well, this is actually not in presentation mode, is it? Sorry about that. Let me try again. Can you still see that?
Yes.
We can still see that.
Yeah.
Yes.
Yeah.
Great, I can't see you now. All right, so essentially what we're going to be doing is getting to know everyone who's involved in the program through these type of events, and we've already attended a few workshops where we've discussed some potential implementation issues and how the program might need to be adapted in different contexts. We are in the process of preparing an ethics amendment, which Hazel is helping me with, which will just be an amendment to add the qualitative evaluation component to the already approved trial. So that's our current step. And then once the trial is done, we'll be conducting focus group with different stakeholder groups. So that will include patients, GPs, and health services staff who are involved in the program. And then we'll be doing some qualitative analysis using an implementation science framework. So I won't go into this today, but essentially this is a very well-known and widely used implementation science framework that just helps you think through what are the different things that make the program work well or not so well in different settings, and how do we need to adapt it to make sure it's sustainable beyond the life of this particular project. And then finally, we'll be doing some reporting through presentations to stakeholders and hopefully a research paper in the end. So just to go into a little bit more about what's involved in the focus groups, if you choose to participate in this bit of the trial, we'll be conducting 6 online focus groups aiming for 6 to 8 participants each, and we'll do separate groups for the different stakeholder groups. So the patients will have their own groups, the GPs will have their own groups, and the health services staff will have their own groups. But we may bring all of those stakeholders together at the end as well. In terms of participants, we just try to get what's called a purposive sample. So we're trying to get diversity in terms of things like gender, age, professional roles, how senior the staff are, that sort of thing, to make sure that we're covering a range of views. And there will be payments covered by the project for the staff who choose and the patients to participate in this aspect of the project. So as I mentioned, we'll be using this implementation science framework, which is known as CIFA, to guide the questions, but it will be semi-structured, which means we can be a bit flexible depending what issues arise in the different focus groups. And we expect there'll be some interesting differences in the different settings that we're running this program in. And in terms of the research data side of things, the focus groups are audio recorded as a group discussion, and then we transcribe them before using a thematic analysis method called framework analysis. So just to summarise, we'll be recruiting 3 groups of participants, running 6 online focus groups, and then we'll be analysing those using a 5-step process, and it will be great to see what we come up with by the end of that. So I probably won't go into this last slide in too much detail, but these are the type of questions that we're hoping to answer through the qualitative evaluation. So things like how the eCare model itself may be needed to be adapted to different local contexts. What are the really core components that are sort of non-negotiable versus the things that can be a bit flexible, and how we implement that as we roll this out or scale it up further. Looking at issues around the inner and outer setting, so what other supports are available to GPs and health services staff via PHN programs and other national programs. And also the role of individuals, so particularly in the general practice research we do, the practice manager is so important in administering these sort of programs and has a really different perspective than other allied health professionals or nursing staff who might be involved as well. So we really want to understand how the different roles play a part in the success of this program, as well as the processes that we need in terms of GP systems and clinical workflows. So I'll just leave it there, but happy to answer any questions, and you may hear from myself and Hazel later on in the program.
Thank you. Thank you so much, Carissa and Hazel. We actually come to the end of the presentations, and as I mentioned, there are questions, dedicated question and answer sessions. After Gideon will be presenting more on the details of the trial. So Gideon, please.
Yeah. Yes, hello everybody. Let me just get these slides up as well. And wonderful. So everybody should be able to see my screen now. Good evening all, I'm Gideon Mavritz-Katz. I am the Research Manager for Western Sydney Diabetes. I've been working with, I think, pretty much everyone here for several years, and we spent a lot of time and effort putting this project together, and I have to say I'm very happy and a bit proud to see that we're finally discussing actually implementing this randomized trial. So we were very fortunate to receive a grant from New South Wales Health. I'm sure this has been mentioned before, translational research grant, to implement this eCare trial. And what we are essentially doing is evaluating this online methodology that we have previously piloted. So Glenn and the team, the story goes back to 2019. I don't know if Glenn covered this because unfortunately my computer crashed just as his presentation was starting. So I missed Glenn's presentation. I won't go into too much detail about the background, but just to say we started this journey some time ago, and we're now moving forward in collaboration with everyone here. So what is eCare? Just a brief overview. Joint GP specialist case conferencing, continuous glucose monitoring, support from the diabetes educators, virtual education, and practice audits. What that means in practice for practices that participate in this program is that we will be providing all of these services as part of the clinical trial. So GP specialist case conferencing, which is going to be provided by either Glenn and the team here at Western Sydney Diabetes, or by Professor Wong and Professor Wu, Ted and Jensia from MetaDiab, in collaboration with the Western New South Wales Diabetes Hub, where we bring there is a specialist case conference. Usually we hold these with the patient at the GP practice and bring our team online. So it's a model that we've been running very successfully locally in Western Sydney for many years. And with all of the virtual technology, Glenn decided that it would be a fantastic idea if we could also implement this in rural regions as well. So for the purposes of the trial, each patient gets an initial consultation, an initial specialist case conference, and then a follow-up case conference as well. And then the purpose of those two case conferences is firstly to enhance that person's care, and secondly to provide education to the general practitioner and to the general practice as a whole, so that they can then manage the person's care from that point forward. Obviously, because this is a clinical trial, there are fairly specific requirements around how that service is provided. But if they do require follow-up, we will be referring on they can be referred on either to MetaDiab to see to have more case conferences with the team, or to the Western New South Wales Diabetes Hub for further local follow-up. Obviously, we provide CGM to all of our patients at Western Sydney Diabetes. So for the trial, every patient who participates will have a CGM 2 weeks before at least 2 weeks before their case conference. The idea here is to identify issues they may be having, to provide as detailed an overview of their diabetes situation as possible, and that allows the specialist team to provide a great deal more insight at the time of the case conference. That CGM we have funded, so it is free for the patient, and we will be providing one for each of their case conferences. Obviously, educator support I don't need to go into in any great detail. We have a fantastic team here at Western Sydney, and I know there's a fantastic team out at Western New South Wales as well. So that provides help with the case conference and with the care moving forward. We also have a very broad array of virtual education materials for both patients and providers. This includes Health2Sync. So Health2Sync is a diabetes self-management platform that includes a mobile application, a clinician login, and a wide variety of useful functions. We've been working with Health2Sync since about 2019. It's been quite a long journey with Health2Sync. They have a fantastic offering, and so all patients within this trial will receive a year's subscription to Health2Sync, and they and that interfaces with their continuous glucose monitoring, and it interfaces with the care that we can provide them. They also will get access to our educational videos, which now I believe it's even more than 120 plus. I think we're up to something around 150. Correct me if I'm wrong, Glenn, but I think we've got quite a few produced so far for both providers and patients to enhance diabetes self-management. The Health2Sync includes an integrated AI enhanced advice functionality. It's also come a long way. The initial AI offerings were a bit less impressive, but now I have to say I've tried it myself, and I was quite impressed by how good the advice is becoming. And we also provide access to NADC diabetes courses and support from our masterclass series for GPs. The other thing that we will be providing as part of eCare and that we provide generally in Western Sydney is practice audits. These will be online for the purposes of the trial, and they are basically, we will sit down virtually with the practice team and go over the numbers in your practice regarding diabetes. What we find is that this often helps practices identify shortcomings in their or potentially a lot of data areas for improvement in terms of how they're capturing their patients with diabetes and what medications they might be on, and perhaps people who may have slipped through the cracks. And it's a very useful way to review your own practice with the specialist team and to identify how you may be able to improve in terms of diabetes care. And again, we'll be offering this for all of the practices who are enrolled. It sort of depends, I think, on the practice themselves, how many audits we do during the trial, and we may have to discuss how that works moving forward. In terms of what's in it for the practices, it's very important to know. So firstly, we offer some reimbursements for both practices and general practitioners who are involved. We have $2,000 per practice for the practice as a whole to reimburse the costs of participating in the trial, $500 for each general practitioner as well. Obviously, you can use your usual MBS billings as a specific item for case conferencing that I know. Oh, sorry, I'm getting a bit of background noise. It's gone now. Wonderful. Support for CGM, and we are currently running a somewhat similar trial in Western Sydney, also a cluster randomized trial. We are finding that some general practices require quite a bit of support. Some general practices require very little support. We have a clinical trial coordinator for this study, a full-time clinical trial coordinator who will make things as seamless as possible. And I know that in the scheme of things, the reimbursements are mostly there to assist with any costs that GP practices may incur. It's not a huge amount of money, but along with the clinical trial coordinator and the reimbursements, we're aiming to make it as easy as possible to participate in the study to benefit both patients and practitioners. I'm more than happy to have a discussion with anyone who wants to chat about what worries they may have. I'm obviously going to be online to answer any questions tonight, but if you want a one-on-one chat, I can go over. We've done this before. We know that GPs and GP practice managers, nurses, community health nurses, everyone is very busy. Practice nurses, sorry, everyone is very busy, and it is always somewhat challenging to incorporate clinical trials into your workflow, but we can make it as easy as possible so that it is almost seamless. In terms of the specifics, when you're thinking about which patients can be included, there aren't a great number of inclusion criteria. Basically, people with type 2 diabetes who have a smartphone that can run the Health2Sync platform, which is these days most smartphones, and a recent HbA1c that's greater than 7.5%. The exclusions are basically people who are sufficiently unwell that they need to be seen more urgently than an outpatient case conference. So if they're on dialysis or they're experiencing current psychosis, that sort of thing. We are running a very specific type of trial, and I know I've used the words cluster randomized. The cluster means that we randomize at the level of the general practice. So rather than randomizing individual patients, what will happen is, and it's a specific type of cluster randomized study called a stepped wedge trial. So the way this works is every practice in the first 8 weeks, we train everyone up. We make sure all of the GP staff have done what's called good clinical practices training, GCP training. They've been trained in the protocol. They understand everything that's gonna happen. It takes that all of that training is about 3 hours. So there's a 1.5-hour online training for good clinical practices training, and then protocol training usually takes about another hour and a half. Not everyone needs to do both of those, but we usually recommend that anyone who's going to be recruiting patients does attend both. After that 8-week period, we spend, this actually says 16 weeks. That's incorrect. I think that was an old protocol. It's going to be 8 weeks, so we spend 8 weeks recruiting as many patients as we can. What we're asking each practice to do is to recruit between 10 and 20 people with diabetes. If you don't think you can manage that, there's still the possibility of participating in the trial. We may just have to discuss exactly how many patients you are able to recruit. But so for those 8 weeks to identify 10 to 20 people who need case conferences and can participate in this study and are interested in taking part, recruit those 10 people and take baseline assessments. So that's basically just ordering the standard pathology panel for people with diabetes and getting them to fill in a few questionnaires. In particular, we need HbA1c for everybody involved in the study. And then over the next 32 weeks, each practice is assigned to a study cluster, and clusters start the intervention at different times. And what you end up with, if you look here, is a bit of a, it looks almost like steps. So you've got this group of people in period 1. Group 1 starts the intervention in period 1. Group 2 starts the intervention in period 2. Group 3 starts the intervention in period 3, and Group 4 starts the intervention in period 4. And so this basically mimics the normal rollout of a program. If Western Sydney Diabetes were to provide case conferencing or eCare to practices in Western New South Wales, it would look like this. The only difference is that instead of implementing our program in an arbitrary manner, we're implementing it in a random manner that's decided by a protocol, by an algorithm, and because of that, it provides us a great deal of power to understand the benefits of the program. And it also means that every practice and every patient who's enrolled in the trial gets the intervention during the trial period. Everyone is going to have eCare at some point, and because of the nature of the intervention, it's going to be a relatively short period from when we start the trial to everyone having seen the specialists through eCare at least once. So this basically just goes through the participant journey. Obviously, they have to consent first. And an important point that I should note while we're discussing this is we do have ethics approval. I know this has been mentioned before. We have ethics approval for the study through Greater Western Health Research and Ethics Committee. And so there are very few barriers to getting underway. The main hurdle is for interested practices. We have a contract that I can send you, a draft contract. Obviously, I know people will want to review that themselves, and if they're comfortable, sign and send it back. The follow-up, we have recently recruited a clinical trial coordinator who should hopefully be starting in the next few weeks, so we can hopefully get all of that up and running as quickly as possible. The timeline at the moment, we are a little bit behind our anticipated timeline, but we are aiming to have, if all practices start recruitment of that baseline, if we go back to here, getting these baseline measurements started towards the end of July or early August. So there is a bit of urgency. If you are interested in getting in contact, the sooner we can get people enrolled, practices enrolled in the trial, the sooner we can start and get these services out to as many people as possible. We're assessing a range of outcomes. I mean, in terms of what this means for individual general practitioners, I think the main things that we ask people to do is the standard diabetes-related pathology, including HbA1c, eGFR, lipids, that sort of thing. We will also be requesting access to some practice-level outcomes that will provide us some information on how the practice did as a whole. And we'll be sending a range of questionnaires to the patient online so that they can to assess things like health-related quality of life, and we'll also be looking at area level outcomes like hospitalization. This is basically looking at the follow-up. I think 9 months is hopeful, but we may not be able to have 9-month follow-up for all participants. But it's just it gives you an idea of what we're going to the burden or the amount of follow-up that each person requires. So to just quickly reiterate, every person who's involved in the trial will need a baseline assessment. Then they need a review, which would usually take place at about 3 months, with repeat pathology and various surveys. And then 3 months after that, we would ask practices to recall their patients to redo the pathology, and we will send them a range of surveys and other things. So that's all from me. I can see that there are a number of questions.
you. I think Glenn has answered some of the questions, but there are questions about the step-wage cluster randomization. Maybe Cam, would you want to just say your question and maybe discuss with us directly? Yeah.
Yeah, thank you. Sorry, I just got the question and just pop it in for you to look at it later. Not meant to interrupt your presentation.
Oh, no, that's okay. I'm more than happy. I can answer this question. It's a very
interesting trial. Yeah, very interesting trial. I'm doing some clinical trial at Westmead Priory Research Centre as well, and Bathurst Rural Clinical School in Western Sydney. So I'm very keen about let's just come to this, which you just finished talking about. Would your randomization algorithm account for practice resources and size as well? Because some practices, as you can see, they can get 32 weeks in the whole block. Yeah, when they're the earliest onboarded and earliest randomized bit. Yeah, compared to someone to come a bit later, they got an 8 weeks block. So what is your logics of that?
So that's not actually quite how the randomization works. The way it works is you have 8 weeks where the patients are seen initially, and then shortly after they're followed up. That's the sort of intervention period. Most of the patients will probably be followed up slightly more than on the 8-week period, but the initial consultation happens within that 8-week period, and then after that 8-week period, those practices have no more new consultations. So they are part of the intervention because they have already received the intervention, but the part after that initial block becomes their follow-up period, their post-intervention period. And so the way that this sort of clinical trial works, it's actually a very useful way to get high statistical power. I won't get into the technical details of why that is, but you compare people against themselves and against the other practices who haven't yet received the intervention, and so you get a very high degree of statistical power and the sort of pragmatic benefits of the structure of the trial. But yeah, so to answer your question, each practice gets the intervention for 8 weeks. So you don't need to take practice size into account. Ideally, I mean, in theory, the randomization should account for practice size. So you should get clusters with reasonably equal practice size in each cluster.
Okay, because when I look at that triangle, that chart, look like the first practice, they got intervention all the way throughout. And then the second one comes in 8 weeks later. Yeah. But it sounds like after 8 weeks of that, they do not do any more active.
Yeah, so let me just bring this back up. Sorry, I realize this is a little bit confusing. Perhaps I should have changed these from intervention to sort of follow-up. But if you see the first bit here, this intervention block, that's when you receive the intervention, and then every period after that is follow-up, where they're no longer receiving additional case conferences in that period.
So that makes sense, because when I see they got 4 interventions in that will blow out that disproportionate kind of things that, some people got 4 blocks and someone got 1 block. But anyway,
no, I understand the confusion. No, that's a good piece of feedback. I understand how that could be confusing.
Do you have any more question, Cam, just before we move to other person?
Oh, I think I'll let someone else to speak for that. Yeah, thank you.
Sure, thank you. Alison.
Yeah, this sort of follows on from that question. So obviously that 8-week intervention period is when they're getting their initial consultation. If they're going to have a follow-up consultation, that can occur in the subsequent weeks, or does it also fall within that 8-week intervention period?
I think ideally we would be looking to try and keep the consultations within the intervention period, but because for practical purposes, yes, they may fall outside of that initial 8-week period.
Yeah, and my other question was in terms of allied health support. So particularly with the meta-dyad model of case conferencing, where if there is existing allied health in the community, they can often be brought in on that case conferencing. Will that still be the case as part of the trial, or will that sit purely with the Western hub for the trial purposes?
Absolutely the same. If there is existing allied health, more than happy to have them brought into the case conferences. I think the purpose in this of the trial is very much to interface or to integrate as neatly as possible with existing services. The whole idea behind this trial, and really the reason that we structured this as a clinical trial, is that at the end of the trial, we want to convince New South Wales Health to fund this program or a program a lot like it moving forward. And to do that, we need it to work for everybody, and we need it particularly to work for your communities. You know, we can't make this happen without all of the local providers who are currently providing services. So yeah, absolutely. If you have local allied health, we would love for them to be on board. We're happy to engage with them, to have a chat prior to any case conferences. If there are other local people that you'd want to bring into the discussion, again, more than happy to have a chat with them. It's very important that this isn't just sort of yes, it's a clinical trial. It has to be a clinical trial because we've got clinical trial funding, but it's also trying to establish it as a service and make sure that it does something meaningful.
And I guess as part of that, do the allied health staff in community need to do anything, like they don't need to do anything differently? Like, do they need to be aware that the practices are participating in the trial, or is it from their perspective, is it just business as usual, routine care as we would normally do, and the practice is just doing additional reporting and doing their involvement in the clinical trial? Like, is there any additional expectation on the allied health providers to fulfill the clinical trial requirements?
There's nothing additional from the clinical trial end, just the usual case conferences. And I think Glenn wanted to add something.
So Marathon is a really important stakeholder in this area. So I think it'd be really good to have some conversation with you about what is being offered in the allied health space with the diabetes educators. And also, we are also implementing a little bit of all the digital solutions. So any major group coming in and getting involved, we welcome you, but we'd like to orientate you to the process that we have underway.
Yep. I have one final question, sorry. Is eCare and metadiab available outside the clinical trial for practices? Like, is that continuing at this time?
So for the purposes of the clinical trial, the full eCare program is only available as part of the clinical trial, but I know metadiab is also offering services through their standard model. And Glenn, did you want to?
So I'll let Jensen answer that because she's on here. But one of the difficulties of this whole trial, because it is a step-wedge randomized control, is that we have predetermined when the intervention is going to happen. And many of the patients that you may see that you may want to refer to us may need more urgent care than that. And we don't want them to not get that. So then they can go off and get that. And I believe that metadiab are offering case conferencing in the usual sense. That Western Sydney Diabetes will put all of its energy into the trial, but you'll have access to the usual services, including metadiab. Do you want to comment, Jency?
Yes, exactly. So metadiab will provide case conferencing as part of the trial, but for practices that are not enrolled in the trial, we'll also have that offering. Obviously, if we're partners in the trial, then the priority will go to support the trial. But there are also other clinic types, such as the metadiab ACE clinic, which is just a single consultation with an endocrinologist. That will be ongoing and independent of the trial.
Okay, fantastic. Thanks, guys.
Thanks.
Yeah, it's probably important to note just to add that the trial is a relatively small number of patients, and it sort of has to be because we're trying to get as many clinics as possible enrolled. So yeah, there are other services available.
Is there any questions from everyone, Gideon, or anyone that has presented today?
If you do have questions that you think of after this or that you don't want to ask right now because it's late and everyone wants to get to their various families, please send me an email. More than happy to chat. I can hop on Teams or give you a ring on the phone. Yeah, I'd love to have as many people involved as possible.
Yep, Genesia?
Oh, I just wanted to add that it's with respect to the MetaDiab case conferencing, just the usual care. We can't provide the usual supports and the technology add-ons, which are the real value adds to that will be part of the trial. So so MetaDiab, just the usual offering won't have CGM necessarily or access to the AI health to sync type innovations, so that won't be part of the usual offering, and that's the value add, I think, for being part of the trial.
Yeah, thank you for flagging that. Yeah, it's a different model, so a different offering as well for that model that Genesia mentioned. Cam, you have another question?
I just got a last question. It's about your CGM, that how are you going to integrate that into the patient's medical record or data for future reference? Or, I mean, to simulate that if there's going to be ongoing things, how are you going to integrate some of those, data that you collected?
Well, for the
I can
purposes,
answer that, Gideon.
Go for it, Glenn.
So these days, we use a lot of CGM in our practices outside of a trial, of course. When you put a CGM, you get an AGP report, which is a comprehensive report, and that becomes part of their clinical record.
So it can be printed out or can be electronically exported to the record, patient's record?
So for us to be able to see the CGM, we have to get an upload. In our patients, it's mostly because they collect it on the phone, we get it from the cloud. But if they can't do that, they're given a reader, and then the reader is uploaded, and then we can look and talk about that report.
So but by the time they come to the GP will be having that report in front of them instead
Yes,
of
that's what the case conference will actually spend a significant or a good part of the time looking at that together with the patient.
Thank you.
Thank you, everyone. We still have time. Is there any last minute questions before we end the session? Like Gideon said, you can contact Gideon directly or myself, or maybe reach out to Katie or our colleague in PHN if you have any questions, and they can definitely referring it to any of us here with your questions. Okay, I've seen none. I maybe just give it back to you, Katie, to close today's sessions. And thanks again.
Thanks, Bea. And look, thanks everyone for coming, and thanks to everyone who presented. There was a question in the chat about presentations, so we'll make sure that we get all the presentations and information out to everybody who's attended, but we'll also send it to those who registered as well, along with a link to recording. Yes, and please do definitely reach out. We're very happy to put you in contact with Gideon or whoever from the team to have further discussions. And we're really excited to see how the trial goes. So wonderful to see you all. Thank you for your time after hours. And if there's no other questions or comments, everyone can go and have a lovely evening.
Thank you so much for coming tonight, everybody.
Thank you.
Thank you
so
all
much,
so much.
everybody. Thank you.
Cheers.